Good morning. Thank you very much for joining to us today. As you know, we are running a EU Horizon 2020 supported RareBoost project for the rare and undiagnosed disease that is given to IBG. Through this, every month we are organizing seminars, and today we have our guest from Istanbul University, and he's and also an old friend of mine. We have been worked together for many years, and he's a professor in internal medicine and in rheumatology, and his research mostly focused on immunopathogenesis and genetics of inflammatory rheumatic diseases such as Behçet and FMF, Familial Mediterranean Fever, and as well as drug developments for those particular diseases. And he has extensive international collaborations, more than 200 publications, and also currently president of International Society of Behçet's disease, and he's also a supporter of IBG, currently a board member of our center. And I welcome to Ahmet Gül.
Well, thank you very much for the warm welcome to both the president of the university and the director of the institute, and also my dear colleague and friend Rozbek for the kind invitation. Well, the topic is about a rare disease, but I will talk you about a disease which is designated as a rare disease, but not a rare disease. So this is the dilemma, but we have many advantages about the condition of the disease and what it opens us in terms of opportunities and also some other aspects. So these are my disclosures, especially the last one is a TÜBİTAK platform, inflammasome platform, mainly dedicated to develop drugs and biomarkers for inflammasome-associated disorders. And at the end of my talk, I will briefly mention these studies as well. So this is my talk plan. I will talk about FMF, Familial Mediterranean Fever, and its clinical diagnosis and then genetic problems. And also, after the definition of FMF, the other part of the beyond part of the talk will focus on the other pyrin-inflammasome-associated inflammatory conditions, not FMF, but pyrin-associated conditions, and also their management in terms of the drug selection and the development of new medicines. But I will first start with a patient. We followed this patient for years, and that was actually started many, many years ago when we have limited opportunities for the treatment. So the patient is, I did not do anything, but okay. When he died, he was 58. His complaint started at the age of 7 with self-limited arthritis attacks, usually with some kind of redness, mainly affecting the knee and ankle joints, recurring every 1 to 2 months. At the age of 8, he also started to suffer from recurrent abdominal pain, peritonitis attacks lasting a few days and then recurring again in every 1 to 3 months. And at the age of 28, he started to suffer from hip pain and also morning stiffness. Unfortunately, he was diagnosed with FMF at the age of 30, nearly 23 years later after the first complaint. And with this diagnosis, we also diagnosed spondyloarthritis, ankylosing spondylitis in association with FMF, and later genetic screening revealed the most penetrant variation M694V homozygous for the patient, and he started to use colchicine 3 times a day. but the patient was not compliant with the medicine. And at the age of 44, he presented with us nausea and vomiting, serious limitation in hip joints and axial movements, and we noticed that he has serious nephrotic range proteinuria. And the biopsy confirmed the diagnosis of AA amyloidosis. And at that time, we did not have a real pathogenesis and then the targeted treatment, so we added azathioprine as an immunosuppressive medication, which was the rule at that time to treat the underlying inflammatory condition. It helped to some extent. Between the age of 44 to 47, he started to suffer again some additional joint problems, but amyloidosis progressed. And at the age of 50, he required to have hip surgery and then kidney transplantation. At the age of 55, he started to receive anakinra for the first time, which is the targeted treatment of the disease, because only at that time the treatment was available. But unfortunately, at the age of 58, we lost the patient because of progressive amyloidosis, mainly affecting not only the kidneys, affected the transplanted kidney, the heart, intestines, liver, and all organs actually in the body were involved. So unfortunately, he died of cachexia and heart failure. So we are talking about a group of disorders in the last century named as recurrent hereditary periodic fever syndromes. So these patients were usually characterized by recurrent attacks of fever plus some other inflammatory findings such as inflammation in serosal membranes, peritonitis, pleuritis. But interestingly, these fever and inflammation attacks were actually sterile, so there was no infection, self-limited. They are healing without any other treatment, usually within days or weeks. And they were monogenic, and they usually showed an ethnic predilection. And the most common one was the one we know as the Mediterranean fever, because that was much more prevalent in the Eastern Mediterranean countries. And at that time, some other investigators described familial Dutch fever, familial Hibernian fever. So the other forms of hereditary periodic fever syndromes were described later on. The original description of the disease dates back the early days of the 20th century, but the naming of the disease as Familial Mediterranean Fever is actually around 1950s. And this is the original paper naming the disease as FMF, Familial Mediterranean Fever, and describing in detail all the clinical findings. Heredofamilial, and mainly affecting the people from the Mediterranean region, usually starting during an infancy or adolescence period, and is characterized by recurrent attacks of inflammation, usually short duration inflammatory attacks, mainly involving abdomen, chest, or joints, singly or in combination, and usually terminating with renal involvement and kidney failure, which is actual amyloidosis. And at that time, they did not describe this as an amyloidosis. But in the later study, which was published about 10 years later, they reported from Israel about 470 cases. And the main features of those cases were involving attacks of peritonitis, arthritis, pleuritis, some skin findings, erysipelas-like erythema, and amyloidosis at that time. And that was really quite frequent. In untreated patients, amyloidosis usually was developing in about 20 to 30% of individuals. That's quite high compared to other inflammatory conditions. That was the original description. And the second big improvement in the disease came from just an observation. That was actually not a planned observation, but colchicine was found to be effective, not only in preventing the attacks, but also in the preventing amyloidosis. So the colchicine is an alkaloid isolated from Colchicum species, which is a very nice flower, and the colchicine has been used for the treatment of gout and many other inflammatory conditions for more than 3,000 years. So the original papers actually dating back to Egyptian papyrus, and then in around 500, somebody from Alexander from some region in Aydın, very close to here, in his book, he published the favorable effects of colchicum in the treatment of gout. So it's been really a miraculous drug at that time. But for the first time, it was used for the treatment of our patients in Istanbul Faculty of Medicine with one of my old cardiology professors, Emir Özkan. He was from Sivas, and he had many patients coming from Sivas. And those patients, some of them were reporting to him that, okay, that was at that time a medicine, a combination of a non-steroidal drugs with colchicine, and they were using this drug for the treatment of their arthritis just because of its similarity to gout. And they reported to him that, okay, this is really helping us. And he started to use colchicine for his patients. It showed very good effect. And then they did a trial. But even at that time, we had a problem of publication. So they could not publish their observational study. That was actually a very good clinical study. And they published that one in Istanbul Faculty of Medicine journal. That was the English journal, Medical Bulletin of Istanbul, Faculty of Medicine. But at the same year, somebody from New York published a short letter. And in this letter, he published his observations with colchicine in FMF patients. And everybody knows that the Goldfinger is the first person who used the drug, originally actually, in the same year, there was a published work of a clinical study documenting its efficacy. And afterwards, in 1974, two papers studied officially the efficacy of the drug, and it was shown to be effective in the prevention of attacks in the majority of patients, and also in the prevention of amyloidosis. Because amyloidosis was the most dreadful complication at that time, and about 10 years later, again from Israel, when they reported their observations with colchicine, they identified that only those patients who were non-compliant with colchicine were developing amyloidosis. So when it's used effectively at the right dose continuously, it was quite successful also in the prevention of amyloidosis. So it was another miracle. The gene was identified about 10 years later. In 1992, Dan Kastner's group mapped the gene to chromosome 16, the short arm of chromosome 16. And at that time, we had only microsatellites. And depending on the number of microsatellites, they were trying to map the gene. So mapping a gene using a whole genome was a big project, not a project of a PhD student. It was actually taking maybe a few PhD students to complete it. And after the mapping, it took 5 years to isolate the gene. In 1997, they published the paper. Actually, two competing groups published at the same time, one from France, the other from the NIH, and they both identified the same gene. And they identified actually 4 mutations in total, 3 in the NIH group, 4 in the French group. M694V is still the most penetrant variation. But originally, when Dan Kastner's group found M694V, they considered that, okay, it's possibly not a pathogenic one. A change from methionine to valine is not so critical, and they just ignored it. But when they noticed that the French group possibly identified the gene, they went back and reanalyzed their data, and they again focused on the gene and reported at the same time. And this is a new gene at that time called MEFV, Mediterranean Fever, which is encoding a protein named Pyrin. This is the naming from the American group. Pyrin is coming from pyrexia fever. But the French group was more romantic. They named the gene Mare Nostrum, coming from Mare Nostrum. Mediterranean, RC. But, you know, the shorter one is always preferred. So we named the gene as Pyrin. And the Pyrin is actually encoded by MEFV, which is a 10 exon gene. And we now know that there are several variants identified in the gene, but all of the mutations identified so far is reported from exon 10. So the exon 10 is encoding a region called SPRI, or B30.2, and all pathogenic variants associated with the FMF phenotype is located in exon 10. And after the identification of the gene responsible for FMF, 2 years later, the NIH group identified the gene for the second hereditary periodic fever syndrome, which is known as familial Hibernian fever. And now we call it TNF receptor-associated periodic fever syndrome, or TRAPS, since the mutations are occurring in the TNF receptor type 1. And during the publication of this second gene, they named these conditions as autoinflammatory conditions, mainly to differentiate them from autoimmune disorders, because they suggested that these are a group of disorders mainly associated with unprovoked inflammatory attacks, and there is no contribution of adaptive immunity. There is no T cell, there is no B cell, there is no pathogenic autoantibody. But later on, it was recognized that although some patients are usually developing these attacks without any trigger, but many are developing attacks after some triggers, such as vaccination, cold exposure, stress, or infections. And some patients are developing some kind of autoimmunity as well, based on the very active innate immune response. And current definition of these new autoinflammatory conditions is therefore involving a group of clinical disorders mainly associated with abnormally increased inflammatory response. And this response is usually mediated predominantly by the innate immune cells, but you cannot rule out the contribution of autoimmunity as well. And there is a strong genetic contribution. It shouldn't be a monogenic disease. There may be some complex forms of autoinflammatory conditions as well. Sorry. And now, this group of disorders are classified among the inflammasomopathies, because a few years later, another independent group from Lausanne identified an intracellular multiprotein complex triggered by some cytoplasmic pathogen or damage-associated molecular patterns. And after the recognition of these threats, they are forming a multiprotein complex, and this complex is mainly activating caspase-1. And the caspase-1 is responsible for the digestion of pro-IL-1 beta and pro-IL-18. So after active caspase-1, you are producing IL-1 beta and IL-18, and the same enzyme is also then digesting gastromin D, which is another important protein described later on, which is responsible for forming pores in the cell membrane. From these pores, the activated IL-1 beta and IL-18 is released. And depending on the sensors, there are different forms of inflammasomopathies. So in Pyrin inflammasome, the sensor is Pyrin, NLRP3, NLRC4. There are different forms of inflammasomes which can again activate the caspase-1 at the end. And this is the Pyrin. This is the protein involved in the pathogenesis of FMF. And this is the AlphaFold prediction. And unfortunately, we still do not have the X-ray structure of the full-length protein, mainly because of the very long distances of, let's say, these unfolded regions or the structural problems. At the N-terminal, we have the so-called Pyrin domain. So this domain was identified during the identification of the protein itself. So the Pyrin domain has some electrostatic features and responsible for the dimerization of other proteins through their Pyrin domain. So pyrin is interacting with other proteins with pyrin domain. So the homotypic interaction is critical, and it's mainly an electrostatic interaction. And after a long, again, disordered region, there is a long coiled coil domain, and this long coiled coil domain is then ending with another structure, which is called SPRI domain or B30.2 domain. And this is the region where the pathogenic variants are actually involved. So in this region, there is a shallow cavity, which is the orange here, and we still are not aware of the true ligands interacting with this region. There are many candidates, but none of them has been proven yet. And two critical mutations affecting the binding of the so-called putative ligand are located at the docking site of this shallow cavity, M694V and M680I. They are just at the entrance of this shallow cavity. And at the back of the domain, there is another mutation, which is called V726A, which is another mutation identified in the original two papers, but has a milder effect, which is at the back of the domain and mainly involved in the transmission of the signal to the other parts, to the coil domain. But the critical ones, the most penetrant ones, are these two mutations with two methionines. Okay. And after the identification of the gene, everybody considered that, okay, it's quite easy now. We have a clinical picture and we have now a genetic test, and that was the first FMF meeting, and it was a big festival. Okay, and there were some companies trying to sell their products, the kits, to search these variants. But we later noticed that actually clinical diagnosis is not always overlapping with the genetic findings. So FMF patients with two mutations is seen usually about 70% of patients, 65 to 70%. And now we have new diagnostic criteria, mainly used to differentiate FMF patients from other autoinflammatory conditions. And the new criteria is involving some genetic data as well. But at least just one pathogenic variant, plus certain clinical manifestations, such as recurrent arthritis, chest pain, or abdominal pain, which is lasting 1 to 3 days, because in other forms of autoinflammatory conditions, the duration of attack or manifestations may also differ, is enough. But it also emphasizes that it is an autosomal recessively inherited disease. So you should see at least two pathogenic or likely pathogenic variants. If there is a variant of unknown significance, VUS, well, if it is only one, you can exclude the diagnosis, or you should look for the other, let's say, explanations, VUS plus a pathogenic variant such as. So the combinations are still being discussed. But if you focus on the pathogenicity of these variants, and if you use any one of the available tools, in silico tools, to search these variants, whether they are pathogenic or not, most of them are giving you either neutral or let's say, not pathogenic designation, which is critical. M694V, again, still usually providing no significant change if you use these tools. It's also true for many others. And I will show you how we solve the problem later on. So some other sophisticated methods may really help. As I told you, we can only explain about 65 to 70% of patients, but later on we started to notice that there are some patients with just one pathogenic variation and clinical phenotype. So the patient has M694V in a heterozygous state, but developing disease. And in Turkey, 3.1% of healthy population is carrying M694V. There is no other genetic disease which such a high prevalent rate for a pathogenic variant. In total, MEFV variations is seen 10 to 20% of Turkish healthy population. But even the most penetrant one is around 3%, which means that there should be at least 2.5 million or more individuals in Turkey carrying M694V. So how we will differentiate who is heterozygous carrier and who is heterozygous patient? Well, the most critical issue is phenotype, of course. When they develop attacks as a patient, but when or why they are developing an attack is another issue. Because if you look at those patients, for heterozygous or dominantly inherited variants, we have some known variants being inherited as a dominant way. For example, the deletion of methionine at the same position, 694. There are some families in the UK which has usually a very long history, and they are being inherited with a dominant form, and which is really critical. Or some complex alleles, such as penetrant variation in exon 10, and one of the common polymorphisms, E148Q. Originally, it was thought to be a pathogenic as well, but we now know that it is not a pathogenic one. E148Q is quite common, which is seen usually 12% of healthy population in Turkey, and in Japan or India, it's reaching 20 or 23%. So it's quite high, quite common. But if it is in cis position with an exon 10 variation, it is also causing a problem. Or there are some other patients that we still do not have a second signal. So we prefer to call these patients as multifactorial FM. So they usually have possibly some contribution from other autoinflammatory genes or environmental factors. They have a tendency to develop more inflammatory findings. But if it is an FMF phenotype, we can call them and start a medication, but it depends on many other factors. They usually start to have manifestations a bit later. The attacks are possibly less frequent or less severe, but they do develop a disease. Oh, sorry. And this is the position of E148Q. Since a long disordered region, E148Q, although it's in exon 2, starting with the pyrin is exon encoded by exon 1, then exon 2 is producing a long disordered region, unfolded region, and E148Q is usually located just across the B30.2 domain. Possibly the position of this variation in combination with one pathogenic exon 10 variation is resulting in more penetrant variation. And if you look at the frequencies of these variants, especially in the Middle East, the most penetrant variation, M694V, is in about 7% of healthy individuals in Israel. And in some parts of the old Babylonian captivity region in Iraqi Jews, which is reaching a bit higher levels. But if you look at the Ashkenazi Jews, the rates are much lower and they have less penetrant variations, but they still have some variations. But if you focus on E148Q exon 2 variation, the frequency is reaching 23% in Japan. In Japan, the disease is quite rare, extremely rare, but Japanese colleagues are reporting some inflammatory patients with E148Q, and they prefer to name them as FMF, but their phenotype is not FMF. So I will show you that we have to focus on the phenotype defined originally in 1950s and the genotype associated with this genotype. If it is so high in the region, there should be an explanation. There should be a heterozygous advantage. And many years ago, I published a suggestion for smallpox, because smallpox is actually producing a caspase-1 inhibitor. And these mutations are usually affecting the caspase-1 activity. And if any disease is mainly involving caspase-1 activity, such as the serpins in smallpox, potentially interacting with the disease pathogenesis. And the smallpox mainly affected the Middle East, and then many years later, it migrated to Europe, and Americas, for the first time, encountered with the smallpox with the help of British people. You know, they introduced the the disease to Indians at that time, mainly as a biologic weapon. So that was quite interesting suggestion, but unfortunately, it's impossible to work with smallpox. But later on, with our colleagues at the NIH, we then worked on Yersinia. Yersinia was another deadly disease causing plague, and Yersinia is inactivating RhoA through the effectors YOP-E and YOP-T. They are actually the pyrin-inflammasome triggers, but pyrin activation is blocked by YOP-M. There's another protein and which is responsible for the blocking of the pyrin-inflammasome activation. And when we look at the polymorphisms around these mutations, M694V is preserved. So there's a long distance linkage disequilibrium, which is suggesting that there is a heterozygous advantage for M694V. And later on, studies show that pyrin-inflammasome is interacting with YOP-M, and if there is a mutation in B30.2 domain, YOP-M could not inhibit the pyrin-inflammasome. So those patients carrying exon 10 variation became much more advantageous against plague at that time, and they survived. And with the increased numbers of survived individuals during plagues, potentially the frequency in the region is increased. So that's one of the potential explanations. So this was the FMF part of the study, but if the frequency of this pathogenic variant is so high, it may affect other conditions as well. So there are some cases mainly associated with heterozygous carrier state. So the mutations are mainly affecting, can I have a pointer or can I use the arrow here? Because it's not being. Okay, thank you. So this is the healthy individuals' IL-1 production after stimuli with LPS. And this is M694V homozygous individuals. And this is the carrier, heterozygous carrier. As you can see, even carriers are producing a lot of IL-1 beta compared to healthy controls. So these heterozygous carriers are contributing to the underlying pathology, other inflammatory conditions, if it is mainly involving IL-1 pathway. And therefore, there are some associations with the carrier state of M694V, such as about 2 to 3 times high frequency of ankylosing spondylitis, Behçet disease, some vasculitis, such as polyarteritis nodosa or IgA vasculitis, or PFAPA, which is really a critical component in the development of other inflammatory conditions if the carrier rate is quite high. Even in some conditions with no direct contribution of IL-1 to their pathogenesis, such as lupus, carrier state is affecting the phenotype. So those carriers have a higher tendency to develop pleurisy, pleural inflammation, which is again changing their phenotypic expression. But the story is not over. There are other variants involving other parts of the protein, and the clinical picture is different. So Pyrin-Associated autoinflammatory syndrome is a bit different. If, again, look at the structure of the protein, at the beginning of the coil domain, there's a complex allele affecting the positions 369 and 406. And these positions are affected and being inherited together. It's a complex allele, and the inheritance of these positions are resulting in some clinical pictures. In some patients, they usually are not responding well to colchicine. They are developing different manifestations such as lymphadenopathies or oral ulcers, and they usually have some additional autoinflammatory variants in the TNF receptor gene or mevalonate kinase gene. But if you look at the other manifestations, there are some patients developing a PFAPA-like clinical picture, which is associated with aphthous ulcers, pharyngitis, cervical lymphadenopathy, or they are developing some pleural or pericardial effusions, or they are developing recurrent refractory synovitis or some ocular inflammation, but the clinical picture is not compatible with FMF. So another location, another variation resulting in a different clinical picture. And this is a report from Japan, and they are reporting this patient as an FMF case with chronic recurrent multifocal osteomyelitis. Well, actually, the clinical picture is not FMF. This is, again, a patient with E148Q plus a complex allele affecting 369, 408, and the clinical picture is a CRMO, which is a different clinical picture. And we cannot name everybody having a variant in the Pyrin protein. But if the clinical picture is not compatible with FMF, and their treatment response is not also compatible. And this is another patient with M694V heterozygous state and developing recurrent attacks of erythema nodosum. Or this is another patient with, again, E148Q plus the complex allele, but the clinical picture is recurrent livedoid vasculitis, responding well to colchicine. Pyrin-associated autoinflammation, but the clinical picture is not FMF. So this is the spectrum. So in addition to this complex allele, if you look at the end of the coil domain, just before the spry domain, the position 577, the mutations at this position is resulting in a different clinical picture with attacks lasting sometimes much longer than the attacks of FMF, days or weeks, not responding well to colchicine. And there are some patients reported from Poland, England, or Turkey, but the clinical picture is much more severe, colchicine refractory. Therefore, the clinical picture is really critical. And another one, exon 2. In exon 2, there are serine amino acids, especially the position at 242 serine is critical because this position is the phosphorylation site. And the phosphorylation of this position is critical for inactivation of the protein function. Some patients are having some variants at this position, and they are developing a very severe clinical picture associated with neutrophilic dermatosis, very severe skin findings, high acute phase response. Again, this is not a clinical picture of FMF. And these manifestations are, again, IL-1 beta associated with the increased activation of inflammasome, not responding to colchicine, but responding very well to IL-1 blockade. And this is called Pyrin-associated autoinflammation with neutrophilic dermatosis. And after the identification of this case, we have learned that for the activation of Pyrin, there are different steps. The first one is mainly involving the phosphorylation site at the position 242, which has been usually associated with the RHO-A. RHO-A is quite critical. RHO GTPase is strongly involved in actin cytoskeleton, and many proteins are interacting with the RHO-A function. But RHO-A is then activating protein kinase N1 and N2, or some of the bacterial proteins are again interacting with these protein kinases. And activation of these protein kinases, then activating this site's phosphorylation. And when this site is phosphorylated, 1433 is binding to this region. And the binding of 1433 is inhibiting the protein function. So the protein is under control. But there are some toxins, such as Clostridium difficile toxin, or let's say Clostridium botulinum toxin, the famous Botox. The other one is this Clostridium difficile toxin associated with antibiotic diarrhea. They are inactivating RHO-A. So this is another mechanism of inflammasome activation. Inflammasome sensors are usually recognizing certain threats, and each protein is responsible for the recognition of specific threats, such as some crystals or some other toxins. But in that case, we are now seeing another kind of recognition. So the pyrin protein is not recognizing each one of these toxins, but it's recognizing the homeostatic changes, which is being followed after the exposure to these toxins. So these toxins are changing the RhoA activation, and the changes in the RhoA system is then activating the pyrin-inflammasome. And activation of pyrin-inflammasome is then being activating caspase-1, and then the activation of the IL-1 beta and IL-18. So we need two steps. The first step is the phosphorylation. And usually, if you inactivate this phosphorylation state, if there is no the second stimulation, which is involving B30.2 domain, there is no activation. But FMF patients with an B30.2 or SPRI domain mutation, they are prone to be activated. Just a single activator, which is affecting the RhoA stimulation, is enough to produce an IL-1 beta activation. Sorry. And we have now some functional tests, and these functional tests are mainly testing this hypothesis. So if you use some stimuli, deactivating the phosphorylation state, if the patient is carrying one exon 10 variation, they are much prone to produce either IL-1 beta or much prone to death. So the apoptosis is increasing. So these are the comparative studies. So these are FMF patients, and these are controls, healthy controls, or patients with other autoinflammatory conditions. Only those carrying exon 10 variations are producing high amounts of inflammatory mediators. And also there is a trend. There is a trend for the 2-copy or 1-copy carrier state. So those having 2 copies of exon 10 variations are being died. The apoptosis risk is quite higher and earlier compared to just 1 mutation carriers, and this is the healthy controls. So we have now a test tool which can be used for the detection of pathogenicity of the variations as well. So by using this method or other methods, because this is another tool, using this time a toxin, one of the Clostridium toxins, and testing the production of IL-1 beta depending on the underlying mutations. So this is the M694V. You can see the clear production, but those variants, either some of the non-pathogenic variants in exon 10 or exon 3 or exon 2, there is no IL-1 beta production. So they are not associated with the IL-1 beta production in association with these typical triggers of the pyrin-inflammasome. So we need 2 signals. The first signal is for the phosphorylation affecting 2.42, and the second signal is necessary for the B30.2 domain activation. Some of the hormones are dealing with this B30.2 domain. So if you want to test the first signal, you should use some hormones. If you want to test the B30.2 mutations, you should use either protein kinase inhibitors or some of the toxins. Oh, sorry. Okay, what we did afterwards. I mean, in addition to these functional studies, it's really still critical what are the proteins interacting with this B30.2 domain, which is really quite important to understand the physiologic role and also to understand the second signal. There are many candidates. We are mainly working on different proteins, including beta-actin, but using the beta-actin model, we use a computational method to assess the molecular dynamic changes in association with these variations. We used mutual information profile, which is testing the positional changes for each amino acid in association with the next amino acid into it. And by using these methods, we used the area, the region in the cavity, and this is the area, the surface area. This is the healthy individual and the least surface area can be seen in patients with the most penetrant variation, M694V, which is potentially decreasing the space to interact with its ligands. But the most important signal came from the mutual information profile. So this is the mutual information profile of M694V, which is the most penetrant one. And these are, again, less penetrant variations, and this is usually considered VUS, or variant of unknown significance, with no critical change. Although the position is just next to M694, but this is not so critical as the M694V. And if you just focus on the negative changes in the mutual information, for the first time, we obtained a scale. At the end, the most severe one is the most penetrant variation, and the less negative effect can be seen in the less penetrant variation. So this is actually much more helpful than the available tools to predict the pathogenicity of these variations. But it is taking such a lot of time just because of the molecular dynamic analysis. So we should use some other easier methods. And this is the current terminology or taxonomy now. First, all of the Pyrin mutations are not associated with FMF. So FMF is an historical diagnosis, a clinical diagnosis, and typical cases are strongly associated with SPRI domain mutations. So if you just focus on FMF, which is the historical diagnosis, specifically associated with SPRI domain mutations. But other variants may affect, for example, periodic fever with autoinflammation and neutrophilic dermatosis, the exon 2 variant affecting the phosphorylation site, or CNO-like manifestations, or vasculitis, some other clinical manifestations compatible with an recurrent inflammatory attacks, but not compatible with FMF. Can we use this data for the treatment? Well, this is the most recent recommendation. As a group, we published quite recently, actually last month. And within these recommendations, we are advising all patients should take a proper, let's say, advice for the interpretation of their clinical findings and genetic data. And unfortunately, even in Turkey, medical genetic centers are not so helpful. I mean, their interpretation of the results are quite strange. They are still reporting, for example, R202Q, which is totally nonsense polymorphism. I mean, this is a polymorphism and not changing any function. And it's seen in 29% of individuals in Turkey, and they keep reporting this variation. And they are usually interpreting exon 2 variations in a different way. So the recommendation is critical. And we have to have appropriate treatment. And if you consider FMF as a diagnosis, you should start colchicine, which is helpful in about 95% of patients. And if you use at the right dose and regularly, it's quite helpful. But there are some individuals, depending on their inflammatory activity in association with their genetic background or environmental factors, or some additional inflammatory conditions, and also in association with the limitations of colchicine. Colchicine is quite effective, but unfortunately, its therapeutic range is quite narrow. You can use it between 1.5 milligram to up to 2.5 or 3 milligram. Otherwise, it's toxic. You cannot tolerate it. So if the patient is on the highest tolerable dose of colchicine, but not responding to this treatment, we know the mechanism. It's inflammasome associated, mainly associated with IL-1 beta, and therefore, if you can eliminate the known risk factors, there are some risk factors that you cannot eliminate, such as the genotype or sex, but the delay in diagnosis, such as the delay I showed you in the initial case I showed you, or the drug compliance problem, unfortunately, in almost all countries, the compliance rate is around 70%. So the 30% of patients are not taking their drugs regularly, which is quite important, or environmental factors. But these modifiable risk factors may affect their disease course. And if you do not modify these risk factors, there are many problems. And these problems are usually leading to development of amyloidosis, especially in those patients with another patient in their family with amyloidosis. The risk of amyloidosis is quite high. And the amyloidosis is associated with very high mortality. And when we recently investigated our series of patients with amyloidosis, the majority of those amyloidosis patients in Turkey are still FMF associated. For example, in Europe now, AA amyloidosis is usually seen in association with some unknown reasons, drug abuse, some other inflammatory conditions, but autoinflammatory conditions, FMF, is exceptionally rare because of regional problems. And they are mainly associated with the penetrance of the variations, but there is a very important observation. If we look at the age of onset of amyloidosis, which is usually developing in around 30. If the patient is M694V homozygous, the mean age is 27. If the patient is carrying 2 exon 10 variation as a compound heterozygous mutations, the, again, age of onset is around 30. But there is still a risk even for heterozygous patients. They are developing amyloidosis about 10 years later. So the age of onset of amyloidosis is a bit late. There is a delay, but they still have a tendency to develop amyloidosis. So we cannot ignore those patients. And one is developed, it's not only involving kidneys as originally considered, it's actually a widespread disease. And if you do not treat them properly, it's progressing and mainly involving the cardiac tissues, intestines, and other organs. And in those refractory patients, we have the option of IL-1 blockade. You know, the cost of colchicine, 1 box of colchicine, 50 tablet, is around 130 lira. But if you switch to anakinra, which is a recombinant interleukin-1 receptor antagonist, which is the recombinant form of natural protein, 1 box, enough for 28 days, for 1 month nearly, is 900 euro. But if you switch to a monoclonal antibody against IL-1 beta, the cost is in Europe is around 10,000 euro for 1 injection. It is treatable. It is available in Turkey if you follow these steps, but there is really an unmet need for those patients to define the refractory state and also to develop certain medications. For these drugs, we did most of the preliminary work. For example, for canakinumab, the pilot trial, phase 2 trial was conducted in our center, and which was followed by a phase 3 trial. And if you are running a trial in a rare disease, just 30 or 60 patients is enough to complete 1 trial. The cost of running a clinical trial is much less, and it's very straightforward. So our 1004 project was aiming to develop new drugs, novel biotechnologic drugs for the treatment of inflammasomopathies, mainly aiming to develop drugs for FMF, but at the background, we were aiming to use these medications for other inflammasome-associated conditions as well, and also to develop biomarkers to identify those patients who are refractory to colchicine. So the colchicine is the best drug. Sorry. And that was an Istanbul University project, but we have some other university partners, Koç University, Vezmali Vakıf University, Boğaziçi University, then Acıbadem University, and some industry partners, Koçak Pharma and Onkokoçsel, and also some rebate partners such as Radboud or Slovenia. And we aim to develop first colchicine. Colchicine is a natural drug, as I told you. but we are still importing colchicine from abroad. And there are more than 100 colchicum species in the world, and more than 50 is available in Turkey. And we are still importing it. And available colchicine drugs are not perfect. The bioavailability is not good, and there is no formulation for children, for example. And for the IL-1 activity, we aim to develop nanobodies, because it's much easier to develop nanobody compared to monoclonal antibodies. And you can use E. coli platform, cheaper and easier for Turkey, and also Fab fragments, as well as biomarkers. And this is our collaboration with Yalova. These are the cultivated different colchicums, and we selected Colchicum speciosum, and we are still working on it. And 2 years ago, we organized a festival, and this is from the festival, and they are now in the production stage. And in another study at the Faculty of Pharmacy, we are isolating colchicine from the corms or flowers of colchicum. So it's really an unmet need, and I will tell you why we still need colchicum production, much more important than nowadays, because still it is nearly impossible to produce colchicine in vitro. So natural source is the only source. It is somehow possible, but it's a Nature publication. I mean, it really takes such a long steps, and it's economically impossible to produce high amounts of colchicine. And we are now cultivating and producing different colchicum species, and then trying to isolate colchicine. And for the new colchicine formulations, we have now better solutions with long-acting and better bioavailable colchicine formulations, which I believe would be available potentially next year. And for the nanobodies, this is a monoclonal antibody with a molecular weight of 150 kilodalton with 2 light chain, 2 heavy chains. And this is the antibody of the camelids. So the camels, llamas, alpacas are producing different forms of antibodies with just heavy chain. And they are also producing only the VAH part of the heavy chain. So this is the nanobody. It has just 3 CDR domain, but this 3 CDR domain is still enough to bind very strongly to its ligand. And since it's very small, 15 kilodalton protein, it's quite easy to produce even in E. coli platform. So we had 2 llamas, and we immunized them with 2 different IL-1 receptor 1. And then that was actually came from Belgium. And after the isolation of the IL-1 receptor binding clones at Istanbul University, we produced nearly 130 clones. And among them, we selected the high binding affinity ones at Behçet and now Acıbadem. And if you look at the SPR analysis, we identified very high binding ones. So this is the level of binding of anakinra, IL-1 receptor antagonists, and these are very close to anakinra. And even when you use some functional assays, so we have 2 candidates. This one is 272, and this is much better, 384. So 2 are now binding the receptor and inhibiting the IL-1 receptor signaling at nanomolar level. So they are now being produced first at lab level, and then will be produced at the industry scale. And at the same time, starting with the COVID time, in the COVID-19 platform, we started to produce anakinra and then a mutant form of anakinra just to prevent some biosimilar issues. So we have now a mutant form binding to IL-1 receptor at the same affinity, even maybe better affinity to IL-1 receptor. And at Koç University, we also developed a pegylated model. So the pegylation is critical since anakinra is cheaper than canakinumab, but it requires daily injection. And in some patients, it requires twice daily injection, and it's painful. With pegylation, we are trying to produce some anakinra forms or IL-1 receptor antagonist forms with a longer half-life, which is quite critical for the quality of life. So we are both developing nanobodies and also pegylated forms, and they all are at the end of the lab scale production. But for colchicine, I think that's the end of the story. So initially, we thought that if we produce these medications, it may be possible to use them in much more frequent conditions. So inflammasome-associated conditions are including cardiovascular diseases, obesity, Alzheimer's, neurodegenerative diseases, gout, Still's, Behçet, many other conditions. And many years ago, Novartis conducted a large trial in more than 10,000 individuals named CANTOS trial, and they showed that using canakinumab, you can lower the rate of cardiovascular events in those individuals who already had a cardiovascular disease. So it is an expensive drug, but at low doses, at longer intervals, it may have an effect in the prevention of cardiovascular events. It wasn't licensed, but the same study also showed that canakinumab is lowering the risk of lung cancer or osteoarthritis. That was quite interesting. And nowadays, another company from Europe is conducting a very big study with anti-IL-6 for cardiovascular indication. But along these studies, two big studies conducted with colchicine showed that colchicine with just 0.5 milligram dose is able to reduce the cardiovascular risk between 20 to 30%, nearly 23% overall, by using just colchicine. And after this observation, 2 years ago, FDA approved colchicine as a cardiovascular medication. But in the United States, colchicine is produced as 0.6 milligram tablets. And all of these studies were conducted by using 0.5 milligram. So FDA did not allow to use 0.6 milligram colchicine. And a German company entered the stage and produced colchicine in the United States with the name of Lodoco, which was the name of the study, actually, low-dose colchicine trial. And after this one, just one tablet colchicine became $20. One tablet. So that's a big change. You know, after these changes, there is a big demand for colchicine. So we really need to produce colchicine at higher amounts using natural sources. And colchicine is really quite effective in the prevention of other inflammatory conditions associated with the inflammasome. So that was the original idea, starting with a rare disease model and developing something with low-cost budgets, and then using these medications in much more frequent indications. If you want to run a trial in a cardiovascular disease, Yeşim Hoca is here. I mean, it's nearly impossible for a Turkish company or Turkish state. I mean, it's nearly impossible to cover the cost of these studies. Okay, so these are take-home messages. Well, FMF is not rare in Turkey, but it's still a rare disease all over the world. But it's our advantage, but we should be aware of it, and we should know the limitations of testing, limitations of diagnosis, or limitations of treatment. So this is something still not well conducted in Turkey. The classical FMF phenotype, defined in 1950s, is associated with exon 10 variations. All other variants may show some form of inflammation, but it's not FMF phenotype. So we should differentiate other Pyrin-associated conditions from the typical FMF phenotype because the prognosis and the risk of amyloidosis is not the same. So they are different diseases. Their course and their prognosis are different. And functional tests are available, so we have to focus on these functional tests to evaluate their pathogenicity and also their role in the disease pathogenesis. And therefore, we should avoid naming some of the frequent variations as pathogenic or worse. And if we can use these medications appropriately, it's possible to reduce inflammatory load. And if colchicine is not enough, is not, let's say, good to control disease activity, we have other options, very effective options. When they are used appropriately, it is still possible to reduce all of the complications or other problems associated with uncontrolled inflammation. So thank you very much for your attention. Again, thanks again for the invitation.